Everyone, my name's Tyler Yates. I am the opioid coordinator with NC Division of Mental Health, Developmental Disabilities, Substance Use Services. Thank you everybody for joining us for this virtual OPDAAC meeting. These quarterly meetings are designed to focus on priorities of the North Carolina Opioid and Substance Use Action Plan, with expert speakers and panels composed of groups implementing strategies across the state. Today's meeting is going to focus on primary prevention, early intervention, treatment, and recovery services for youth and adolescents. Before we get started, I would like to just go through some quick announcements and reminders. I want to first say thank you to everyone who has helped organize and plan this meeting, to all the presenters and panelists who are joining us today, and to the Governor's Institute for providing a virtual platform and for hosting this OPDAAC meeting. For those that are joining us online, please feel free to introduce yourself in the chat. During this meeting, if you have any questions, feel free to put them in the questions and answers chat box. We'll do our best to try to answer them either through conversations, or we'll also have folks that are monitoring the chat and the question and answer box as we go through the meeting. If we can't get to your question, someone from our team will reach out to you afterwards, or you can reach out to injuryfreenc at beinjuryfreenc@dhhs.nc.gov. This meeting is being recorded, and the recordings and the slides will be posted online on the NCDHHS OPDAAC website, and an email will be sent out through the OPDAAC listserv and other listservs once the meeting materials are posted online. For more information about the overdose crisis, available resources in the state, or to learn more about OPDAAC, please visit the OPDAAC website or email beinjuryfree@dhhs.nc.gov. We have a very full agenda today, so without taking up any more time, I want to go ahead and turn it over to Meredith Welch, who's joining us from the Office of the Chief Medical Examiner.
Hi, good morning, everyone. Let me share my slides really quickly. Can everyone see my screen?
Yep.
Okay, perfect. Well, I just want to say hello and good morning. My name is Meredith Welch, and I'm the epidemiologist at the Office of the Chief Medical Examiner. Today, I'm going to provide an overview of pre-adolescent and adolescent fentanyl positive deaths in North Carolina. Thank you for having me today. So my plan is to review recent trends in overall and pediatric fentanyl positive deaths, highlight some case examples and prevention strategies, share our resources, and then have some time at the end for questions. So our data, to briefly go over our data, the fatality data are from the Medical Examiner Informational System. Data are based on analytical testing of specimens and performed by our toxicology team. It's important to note that the detection of fentanyl by the laboratory may not necessarily be the ultimate cause of death determined by a pathologist. So for instance, in rare cases where therapeutic fentanyl was administered during emergency medical care, these cases will still show up as a fentanyl positive death. However, these numbers are still a great indicator for deaths where fentanyl was a contributing factor. Additionally, due to small numbers, the data are presented in numbers and rates. While we strive to use rates for standardized comparisons across populations and time periods, some numbers were too small to support a rate calculation. And finally, I want to note that while fentanyl is a major contributor to pediatric fentanyl overdose deaths, other substances still remain a risk of the population as well. So first, I want to share some trends on overall fentanyl positive deaths in North Carolina. So this graph shows the annual number of fentanyl positive deaths occurring in North Carolina from 2015 to 2024. The number of fentanyl positive deaths has increased by 31% since the start of the pandemic in 2019, with a total of 1,954 fatalities in 2024. So moving forward, this graph shows fentanyl positive death rates by demographic groups from 2021 to 2024. The highest rates for fentanyl positive deaths occurred among male residents, American Indian residents, and adults aged 18 years and older. So next, I want to shift focus to trends in pediatric fentanyl positive deaths. So before diving into really specific trends, I want to highlight this visualization. This graph shows fentanyl positive deaths over 10 years. So while the pediatric numbers are low, it's important to recognize that these deaths occur within the context of an ongoing and larger fentanyl overdose crisis. So in 2024, pediatric fentanyl positive deaths accounted for 1.8% of all fentanyl positive deaths. So moving forward, this graph displays a number of pediatric fentanyl positive deaths by year. We see that pediatric fentanyl deaths have increased by 400% since the start of the pandemic in 2019. So while this looks like a large increase, we need to keep in mind that these numbers rose from 7 to 35, and they can appear steep due to the low baseline at 7. So looking at this visualization of numbers of fentanyl positive deaths by age group from 2015 to 2024, we see that infants and toddlers aged 0 to 5 and teenagers aged 13 to 17 have the highest counts of pediatric fentanyl positive deaths in North Carolina. So continuing to look at these age groups, we see that the numbers of fentanyl positive deaths have increased over the past 10 years for both age groups. It's important to remind everyone that because the numbers are small, we couldn't calculate rates. Therefore, we can't standardize the numbers to examine if birth rates or population sizes could account for the fluctuations in the data. So one way to improve stability is by combining data across multiple years. So looking at the 10-year combined rate from 2015 to 2024, we see that American Indian and Black North Carolina residents experience the highest rates of pediatric fentanyl positive deaths. So this is important because for race and ethnicity, we see that these trends mirror what we see in the overall fentanyl positive death rates. However, for the pediatric rates, they were similar for males and females, which we see kind of different from the overall trends in which males have much higher rates. Okay, next, I really want to shift some gears and go over some case examples of pediatric fentanyl positive cases that have seen me. So the first case was a 10-month-old decedent where the grandmother took the decedent to the babysitter's house and a law enforcement found drugs in the babysitter's pocketbook. Next is a 1-year-old decedent that was co-sleeping in bed with the mother. The mother stated that she used a cotton ball of fentanyl and left the rest next to the bed. Next, in adolescents, we see a 17-year-old that was reported using Percocet and Xanax before being put to bed. Oh, sorry. And then last, a 16-year-old was at a party and was witnessed ingesting pills believed to be Xanax. So I recognize that this is a lot of information, and I want to highlight some key takeaways and briefly discuss some prevention strategies. So for infants and toddlers, we see fentanyl powders and residues are much easier for a child to ingest than prescription opioid pills. Additionally, leftover paraphernalia will contain enough potent drug to potentially be lethal to a small child. Lastly, unsafe environments, including unsafe adult sleeping spaces that contain paraphernalia, will increase dangers surrounding fentanyl overdoses. So looking at prevention measures, caregivers must be better informed about risk drug paraphernalia can pose to children. Infants and toddlers need a safe environment. It's important to practice drug-safe storage, as exploring children may have access to unsecured prescription and recreational drugs. As seen in our case example, we see that these exposures often occur in unsafe sleeping environments. For adolescents, there's a growing trend of counterfeit pills, including opioids and benzodiazepines, often taken unknowingly laced with fentanyl. So for prevention efforts, research shows that drug prevention routines must begin early, often before they even reach adolescence. Additionally, both adolescents and parents must engage in prevention efforts by reducing peer and academic pressures, promoting awareness for long-term consequences, and ensuring timely access for treatment. So lastly, I want to leave you all with some additional data and informational resources. These will be linked in the presentation for your reference as well. So first, I want to highlight the monthly fentanyl positive death report. This report provides crucial insights for emerging patterns, demographic disparities, and potential risk factors associated with fentanyl positive deaths in North Carolina. We also produce a monthly county-level fentanyl positive report, which breaks down similar data by county of death. Also, feel free to contact the email link provided if you'd like to receive monthly updates on these reports, as well as emergency department reports. So lastly, linking some studies done by OCME. One current study highlights the accidental or undetermined manner of death of opioid ingestions leading to fatalities in young children. and I provide a URI link for that report as well. And then another study by OCME describes the context and characteristics of suspected counterfeit pill-involved deaths in North Carolina. In addition, a fact sheet was developed in collaboration with the North Carolina Injury Violence Prevention Branch on the topic as well. And lastly, I want to give a big thank you to Dr. Sandra Bishop-Freeman, Laura Friedrich, and Mary Beth Cox for their help and support in making these slides. I've also linked my email if you have any additional questions, but thank you so much.
Amazing. Thank you so much, Meredith. I'm trying to look through the chat to see if there were any questions that came up during your presentation. It doesn't look like any have popped up yet, but thank you so much for sharing this information. I guess we can now shift gears and we'll turn it over to Jessica Dickin to talk about some of the primary prevention work going on in the state.
Great, thanks, Tyler. I will go ahead and share my screen. Can everybody see that?
Yes.
Okay, perfect. All right, so here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services, we primarily work with primary alcohol, tobacco, and other drug prevention. So we're trying to prevent drug use and alcohol use and other substances before they start. We also work with communities, looking at policies and environmental strategies that help change the people and the places and the things that surround youth and young people. But we're also concerned about prevention across the lifespan. Additionally, we do have one overdose prevention grant, which we'll be talking about soon. And so I'm looking forward to sharing with you all of the great work that's going on behalf of DMH DDSUS. So as you all know, opioid use starts early. Thank you to Meredith for sharing some of the unfortunate information about some fentanyl deaths. Certainly, things happen with folks who misuse prescriptions, especially if they get injured in sports or if they have a surgery. There's certainly also polysubstance use in adolescents and, of course, untreated mental health and trauma exposure. The cost of the opioid epidemic in 2023 was estimated to be around $50 billion. I will say that who knows what the 2025 data has, but this also includes medical, social, and personal costs of overdose deaths. And you'll see the overdose death rate projected as of 2024. And this is, of course, from the Department of Public Health. And you'll see a lot of these communities in the red that are the highest, or in that, let's call it mango, that high and middle as well. So you can see across the board how that looks for 2024. I will say, if the opioid epidemic has cost us $50 million, our division has invested $12.4 million. Of course, all of us know about the opioid settlement dollars. We got a lot of money for prevention and treatment services for opioid use disorders. However, it's nowhere near compared to the amount of cost that the opioid epidemic has come into, has created in North Carolina, especially in 2023, and then, of course, in subsequent years. I will say this, the $12 million that we got really does make an impact over the lifetime of folks. And this is not to take anything away from MAT or overdose prevention centers or criminal justice, but the So the investment in primary prevention really costs around $200 to $1,500 per participant for whatever they participate in. And there could be multiple different programs that are offered. And as you see here, here are some particular, these are curriculums, life skills training for young people that serves grades K through 12, Project Towards No Drug Abuse, which is, don't like the language, but it serves high school students, strong African-American families, serves families and parents. And then Guiding Good Choices is also another program that is available. And I will tell you, if one young person, for example, lived to be about 77, and we saved about $14 over the course of their lifetime, or for the $1 spent, it would be equaling about $1,078, and that's just for one person. So if we served 9,000 people, young people last year, so we're looking at a savings of over $9 million across the board by serving 9,000 people. So I would say that the cost savings of evidence-based primary prevention is significant and very important, and it's important to invest in primary prevention initiatives. So you'll see here in North Carolina, we have several different opioid-focused educational and environmental strategies across the board in these different grants. You'll see with the smiley faces, a lot of what we cover are really related to that, the map that I showed you before. We cover a lot of counties that are red or mango. And you can, again, see all of these different places. And certainly the folks who are presenting after me will talk a lot more about what it is that they do and who they serve. But we have 11 preventing drug overdose counties, and that is our opioid overdose prevention grant. We have 7 strategic prevention framework partnerships for success grant that also focus on under-resourced communities in the northeastern part of the state, and that also focuses on prescription drugs. We have 7 strategic prevention framework prescription drug counties that are across the state, and then 10 state opioid response grants that serve statewide entities, and they are covered in Mitchell and Yancey and Buncombe County. And then we have a grant that works with multiple different coalitions across the state, which will also be talked about soon. And we also provide 10 state opioid response of education communities to counties that have a higher than average rate of opioid death and overdose rates. So we really do try to invest our $12.4 million in the places and the people that need it most. And you'll note here, I said we serve close to 9,000 people. We've distributed over 11,000 lockboxes and 15,000 medication disposal kits as a result of some of our work in our regular prevention SUPTERS grant, block grant, which is the Substance Use Prevention, Treatment, and Recovery block grant. We've hosted over 200 medication take-back events where there have been over 1,200 pounds of unused medication collected. And then another thing that's really important to think about is people have really identified that secure medication storage and safe disposal is important to them, and it certainly increased their awareness and use of some of these services. So without further ado, I'm happy to turn it over to folks who make a difference in our communities every day. So we've got a whole host of people representing us today, and I'm very excited to turn it over to them. We'll have our Preventing Drug Overdose grant with Jane Caceres. Community Impact North Carolina will present about Lock Your Meds and the community collaborations with the State Opioid Response Grant. We'll have the Strategic Prevention Framework Prescription Drugs Grant with Kristen Hunt And then I will talk briefly about our Partnerships for Success grant. I'll turn it over to Pivot Point, Western North Carolina with Matt Nanis, PATH with Shell McCall and Kate Zarella, and Insight Human Services and Coastal Horizons will be talking a lot about the work that they do in their communities as well around the education and all sorts of opioid prevention services they provide. I will say that the data and information that we shared today was provided by our evaluators and at Wake Forest School of Medicine and the Pacific Institute for Research and Evaluation, PIRE. So we really thank them for all of the work that they have done to get us to this point. So I am thrilled to turn it over to Jane Caceres.
Good morning. Thank you for having me today. Again, my name is Jane. I am the grants manager for our Preventing Prescription Drug and Opioid Overdose Related Deaths grant, which I will refer to as PDO from here on out. Next slide, please. So this grant is a SAMHSA grant. It was awarded to the state of North Carolina in 2021. And we selected 11 communities through a competitive RFA process to receive about $50,000 per year. And it is a 5-year project. We are currently working in the 5th year of that grant. And the grant is aimed at reducing the number of prescription drug and opioid overdose related deaths and adverse events among individuals aged 18 and older. So when we put out the RFA for this grant, we really targeted this towards communities who had above average rates of emergency department visits related to opioid overdose, deaths related to opioids, including illicit opioids. We also looked at communities who had above average rates of prescribing of opioids. And we also only looked at communities who already had some work around naloxone distribution and community reversals happening in those areas. And so, as you can see, we selected a very wide variety of grantees across the state. We have like all the way literally on the coast to some communities that kind of border Tennessee. We have a good mixture of rural communities as well as urban communities. And I think the very unique thing about this grant is that all of our grantees are either health departments that facilitate their community's primary prevention coalition, or they are historically primary prevention providers. And so I think this just kind of shows that at least in these communities, those individuals are seen as experts in substance use, and people have been coming to them and talking about how can we get more naloxone in our community? How can we improve outcomes for people? And so this is was a very unique opportunity for us to really blend harm reduction efforts or overdose prevention efforts and primary prevention efforts. So next slide, please. So the required strategies for this grant that were laid out by SAMHSA are that communities have to do naloxone distribution and naloxone training, and some of the training has to be geared towards professional first responders. And then there was also this allowable set of strategies that communities can choose to do based on their own capacity. So the allowable strategies were prescriber and dispenser education and training. So training prescribers and dispensers on the importance of co-dispensing naloxone with opioid medications, alternatives to opioid medications and things like that. They can also implement the North Carolina Lock Your Meds campaign, which it'll be talked about later, but it's a communication campaign that's focused on safe storage and proper disposal of medications, building linkages to treatment and recovery services, and then supporting or implementing some type of paramedicine program. Next slide, please. And so some of our highlights of this program is that since October of 2022, we have distributed over 36,000 naloxone kits, and we distribute around 15,000 a year. We've had 3,709 reported administrations to date, and 1,504 confirmed naloxone reversals to date. And we suspect that number is actually much higher, but early on, since a lot of these organizations were just kind of learning and growing into that overdose prevention space, they didn't have the relationships with individuals to get good data back from that. So there were some gaps in that data there, but that is the number of confirmed successful reversals we've had. And I will point out that we've only had 47 confirmed deaths. So some of these were maybe actually not an opioid overdose, or we just didn't get that data back. So, and then we've had just over 1,000 overdose victims and families who have received information about and referrals to treatment and recovery services following an overdose. Next slide, please. As far as naloxone training goes, we have trained over 760 professional first responders on how to recognize the symptoms of an overdose and administer naloxone. And additionally, we have trained almost 3,700 lay people, community organizations, businesses, and even some government agencies on recognizing signs of overdose and administering naloxone. On the primary prevention side of this, we have distributed 6,203 medication lockboxes in our 11 communities. And that's just with this funding. That doesn't include all of the lockbox distribution that they're already doing through other funding streams. And we've distributed almost 6,000 chemical disposal kits to date. Next slide, please. So some of our findings have been that truly collaborations are instrumental in reaching populations at risk for overdose. We recognize that as primary prevention providers, we are not the experts in reaching people who use drugs. And so really developing those partnerships and leaning on those partners to make sure that we are distributing naloxone to people who have the greatest potential to need it and use it. We've also worked closely with shelters, treatment centers, food pantries, churches, and local universities and colleges to do our distribution. And we've learned a lot through that. One really cool example of how building that relationship has led to an increase in services across the board is there was a church that was willing to house a blessing box that would have naloxone in it. And they also already had a food box that people could come and get food out of. That church parking lot was adjacent to a community park. And so when talking about placing the naloxone vending box at the church, someone said, well, hey, because this is beside a park, if you put this on the park side of the church, people who are on the registered sex offender list won't be able to access that because they can't be that close to a park. And so the church was like, oh, that's a good idea. And that means they're probably not able to access our food box either. And so they actually moved that food box to the other side of the church to make it more accessible to all people in the community who might need to access that, in addition to the naloxone and other services. We've taken a very outside of the box approach to the naloxone education. With that, I mean, for example, we've even trained, we've had local businesses approach to ask for training, one being an ice cream shop because they're right across the street from a public restroom. They've seen some overdose events happen, and so they just wanted to make sure that they were prepared to respond in the event that they might be able to help. And maintaining like persistence and timely follow-up has been very important in building those relationships and being able to reach these non-traditional partners. Next slide, please. We've also taken a very strategic approach to our naloxone distribution and access. As I mentioned before, we have a lot of our communities have installed blessing boxes that hold naloxone treatment and recovery resources, primary prevention supplies, as well as some xylazine and fentanyl test strips and other things like that. And we have done this very strategically, in part with Eastern Carolina University through a HRSA grant. And they hired people with lived experience to conduct interviews with people who use drugs or other people with lived experience to really make sure that these boxes and these vending machines are being placed where they can be accessed and that they have the supplies in them that people in that community are most in need of. And so we've tried to be very strategic in everything that we've done to really reach the people who need naloxone. And then all of our communities have worked hard to really build better linkages and better relationships so that more people can be referred to treatment and recovery resources in those communities as well. And next slide, please. But I think that wraps me up. Yep, that's it for me. So I'm going to pass the torch to Holly Carter to talk about the Lock Your Meds campaign.
Thanks, Jane. I will tell you that there have been a couple of questions I will let you answer in the chat and the Q&A about naloxone reversals and how you collect that information. So looking forward for you to share that with everybody. Okay. So how do we collect reversal data? We put QR codes on all of our naloxone kits that we distribute that links back to a survey that just asks like, was this used to reverse an overdose? What was the outcome of that? It does ask some other questions, where did the overdose take place? I think that might be it. It's very short, but that is one way that we collect it is through those QR codes. But we also collect it as a result of our partnerships. A lot of our partners have close relationships with the people that they're distributing naloxone to. And so they'll just ask when they come get a new kit, like, hey, did you use this to reverse an overdose? So we've tried to model that. We've worked closely with the Harm Reduction Coalition to try to model that after what a lot of syringe service programs, how they collect that data. So I hope that answers your question. Great. Looks like there's a couple other questions, but I'll let you do that. Answer
those
in the chat.
Yeah, I'll answer those in the chat, and then we can move on to Holly. Thank you.
Absolutely. All right, Holly, we're excited to hear about Lock Your Meds.
Thank you. Good morning, everyone. I'm Holly Carter. I'm also a team member with Community Impact NC. And there I direct the Lock Your Meds campaign statewide in North Carolina, as well as I am a grants project manager, and I'll talk with you about that soon. Next slide, please. So the Lock Your Meds campaign, I hope you all have heard of it. It is a national multimedia campaign. It's actually produced by a company out of Florida, National Family Partnerships. But the communication campaign is designed to reduce prescription drug misuse by changing storage and disposal behaviors around prescription medications. So we at Community Impact have administered and directed this grant statewide since 2017, thanks to support from NCDHHS. The license agreement for this communication campaign is open for all of North Carolina, so anyone is free to use it. Obviously, that typically starts with the community prevention providers, and then that is shared out with their partners in their communities, so it can be used anywhere. Currently, approximately 90 of our counties do or have participated in the campaign at some level. So the strategies that are used in this campaign are one, information dissemination, and examples of that are a variety of PSAs, and those can go almost in any media outlet that you can think of, as well as social media assets. There are printed materials like rack cards and pamphlets. The message can go on billboards, bench ads, buses. Our community providers have been super creative in some of the ways that they've gotten this message out into their community. And then the second strategy is community-based processes, and that's done through community trainings, plannings, and collaborations. The partnerships are, I could take this entire meeting to share all the fantastic partnerships that prevention providers have created in their communities and the work that they've done with their many partners. And then environmental strategies, which is our biggie. And that's where we work on policies, procedures, and practices around safe storage and safe disposal of medications, reducing barriers to folks, like barriers to disposing their medications, any barriers they have on safe storage, all to reduce access. So access to prescription medications are reduced by the locking cases. So we do a lot of locking boxes, locking pouches, then as well as resources for disposal, whether that be permanent drop boxes in communities, and getting the information out to folks on where those permanent drop boxes are, as well as providing at-home disposal kits and instructions on how to use those so that medications can be disposed properly. And then just changing the social norms, changing it so that it is our norm to secure medications and then dispose of them when they're no longer needed. All right, next slide, please. So just to share a few of the highlights from our statewide success since 2017. So this is overall success of things from a community level, as well as the things that we have done at a statewide level. And these items have been funded under multiple grant streams. Most of the prevention grants that have been mentioned allow Lock Your Meds as one of their strategies. So over 275,000 locking medicine cases or pouches have been distributed as a result of the campaign. Over 275,000 disposal kits have been distributed. Over 1,000 medication take-back events, so like the community medicine take-back events, have been conducted or had participation in order to enhance Lock Your Meds efforts at a local level. Over 575,000 printed campaign materials have been distributed, and approximately 70 of the permanent medication disposal boxes have been placed, installed, or collaborations resulting around through the Lock Your Meds efforts. And over 75 million impressions have been recorded through the different assets on the different media streams I mentioned. So we do evaluate the outcomes of this campaign and community impact, and the state have partnered with the Pacific Institute of Research and Evaluation every 2 years to do a statewide survey to evaluate the effectiveness of the campaign, make sure that we were still on target and still providing North Carolinians with an effective message. We've done those surveys in 2020, 22, and 24. And then in addition, in 2021, PIRE conducted focus groups with community members as well as prevention providers to get their feedback on the campaign. And based on that feedback, we did some updates to the campaign to make it relative to the needs of North Carolina. Since that campaign had been out a while, we had to change some of the messaging around. But overall, and with this last campaign the last survey in comparison with the others, we have seen an uptick, a positive uptick every year, concluding that there is significant success in changing the behaviors and attitudes of North Carolinians around medication safety. So this is just some of the data to be shared from that survey by PIRE. 42% of respondents who recalled seeing the campaign message were influenced to lock up their medication. 25% of the respondents who recalled seeing it are influenced to regularly check and monitor their medications. Next. Next slide, please. Thank you. And also it concludes that those who are familiar with the campaign are 2.5 more times likely to report using a lockbox to store medications in their home. And also those familiar with the campaign were twice as likely to use a proper disposal method, like the drop boxes, a take-back vent, or the disposal kits. Next slide. And that's it. I'll now turn it over to our SPF-RX experts, Kristen Hunt and Melinda Pankratz. Thank you.
Good morning. I'm Kristen Hunt, and I manage the SPIF grant, which is a strategic prevention framework for prescription drugs. Next slide, please. So this grant was awarded in 2021 to 7 communities in North Carolina. Those communities are Robinson, Scotland, Columbus, Caldwell, Mitchell, Surrey, and Wilkes County. And it's to provide resources and address prescription drug misuse by, one, raising awareness about the dangers of sharing medication, secure storage, and safe disposal options. Also increasing CSRS utilization and reduce overprescribing. And I just want to mention, since Holly just talked about the Lock Your Meds campaign, that is one of our, for all of our grantees, one of the main initiatives we use is the Lock Your Meds campaign. Our sites build really good and strong relationships within their communities and distribute a lot of the Lock Your Meds resources to barbershops, pharmacies, faith-based organizations, and a lot of other places in their community. So by 2026, some of the goals are to a 10% increase in prescriber training, a 10% increase in prescription drug monitoring program usage, and then a decrease of 10% in high-risk prescribing in young adults, and a 10% increase in secure storage and disposal. Next slide. So one of the things that's really useful for the SPIF grant are the scorecards that Wake Forest develops for us. And these scorecards kind of give a visual snapshot of the prescription opioid use in the counties. So it's to visualize the scope of the problem and then provide some guidance and some actionable efforts to preventing prescription medication misuse. So if you look at the snapshot, on the left, it has the problem, and it compares, in this snapshot in particular, we're looking at Columbus County, but it compares the prescription opioid use issue and it compares it to the state average. Then it kind of breaks down some of the causes within that community. So each one is tailored to each of our grantees. And then it also includes a snapshot of our greatest at-risk population. So in this case, Columbus County is men and then middle-aged persons from 25 to 54. So this data is really useful for our sites as they go out into their communities, just to kind of give them a little background of the issues within that community and then compared to the state average. And this data comes from the North Carolina State Center for Health Statistics, Vital Statistics, death certificate data, as well as the North Carolina Controlled Substance Reporting System. Next slide, please. So this is the back of the scorecards. And again, it just gives some actionable efforts and resources to both the community members and to healthcare providers. So on the left, you can see for the community members, it just gives them a list of resources. There's a map of Dropbox locations. And there's also just some tips and actionable efforts that they can use as far as not sharing medication with family members, avoid taking opioids with alcohol and others. I'm sorry, avoid taking opioids with alcohol and other substances. Just some things for community members to be aware of. And then on the right side, it shows healthcare provider steps. So for one is registering with the CSRS system, and then integrating that into their electronic health records, engaging in prescriber and patient education to increase the use of safer and more effective pain treatments. And then the last one, this one includes learning more about naloxone and overdose risk factors and considering whether you should offer naloxone to patients prescribed opioids. So again, the scorecards are just a really helpful snapshot of just some quick overview information for both our community members and for healthcare providers. Next slide, please. So another thing Wake Forest does for our sites, they create trend reports. And Melinda, I'll let you go ahead and go into detail about the trend reports for the SPIF communities.
Thank you, Kristen. One of the things that is an important component of this project is they take existing data to use that in communities to identify things that you can do to advance your prevention efforts. One aspect of that was the scorecards that Kristen talked about examples for, but another piece that both provides data that can be used to identify actions in communities and also evaluate how you're doing is CSRS trend reports that we provide to the communities. These reports take data on opioid prescribing as well as controlled substance reporting system utilization data, and that is North Carolina's prescription drug and monitoring program. And these are really important for communities because it shows how things are changing. It also shows where you may have the opportunity to get insights onto what's a problem. One of the things that is different relative to prescription utilization is that there's not really one right level of prescribing in any given community. And so these reports allow communities to think about things that are unique about their population that might influence why a certain type of prescribing might be higher or lower in their community, and to really think about what makes sense and what might be a little bit higher levels of prescribing than is ideal. And so as a part of these graphs, which include data on opioid prescriptions per resident in the county, as well as per resident prescribed an opioid, and they will include both the number of prescriptions, how many prescriptions a person has on average, if they have an opioid prescription combined with a benzodiazepine prescription or with a second opioid prescription, or if there is a high dose opioid prescription, all of which increase the risk of overdose. So communities can look at that, see what is happening and where they might be able to have the most action. We pose questions that communities can use to think about these. A few examples we have included on the slide, looking at how do we compare to the state? Is there anything that's surprising that we should really think about in the context of our community? Why might that be? Is there anything that is going to be especially easy for us to positively influence or that we could impact by multiple strategies or one strategy impacting multiple things? And do we have the resources for that? And in this example slide that I've shown, this is for Robeson County, and it is looking at how often prescribers or their delegates are looking at the CSRS system relative to how many prescribers there are. And in this, you see on the bottom black line, that is the state trend. And so you can see that from July 2019 through January 2024, that CSRS utilization was increasing at the statewide level. It was also increasing in Robeson County, but what you notice in about July 2021, that increase was more elevated in Robeson County, which may be reflected in prescriber trainings or other outreach that was done with people in that community, which those people at the table would know about those things. So these just provide a tool to be able to decide what is the appropriate actions to try to take next, as well as to see, did what we did it seem to make a difference in our community?
Hey, Melinda, just had a question about how do you get data on like countywide data regarding the misuse of prescription drugs? Who do you contact, or how would people go about getting that information?
Excellent question. This data comes from the North Carolina Controlled Substance Use Reporting System. You do have to specifically request this. It is done through the Drug Control Unit at DMH. I specifically work with Savannah Simpson, who oversees that process. And they provide it specifically by county. They are working on trying to increase how accessible certain metrics are, but at the current time, I believe you do have to individually request that data. Another piece of data that SPIFRX communities, as well as others, can be able to use to identify opportunities for prevention is the North Carolina Youth and Young Adult Prevention Survey, which is being conducted every 2 years. Its purpose is to be able to make data-driven decision-making. It includes data on a variety of measures, including substance use, risk and protective factors. It will also include demographics. It talks about how people access the substances they use, and a variety of other things. There's a couple of mental health measures and a couple of harm reduction and recovery measures. This is available to people in a variety of ways, all of which can be accessed through the Prevention Resource Repository housed at Wake Forest University School of Medicine. And we have included the web address for that. But I have found that if you type in Prevention Resource Repository, it will come up close to the top, if not the very top resource. And that at that location, you can access the North Carolina Substance Use Prevention Data Dashboard, which has a full array of the survey data where you can look at it by your region. And there's a variety of regions on there. including our data collection regions and regions for coalitions and prevention providers. There's also survey reports and then papers and presentations. And just as a little snippet of one of the things that you can see, and this is from the main 2023 survey report, is for those who misused prescription medications, what type of medication they used. And as you can see from this data, it showed that our youth from 12 to 20 were most likely to report misusing pain medications, while our young adults from 21 to 25 were most likely to report misusing anxiety or sleep medications. And so that's an important difference in looking at thinking about how you might address prescription medications if you're working with younger adolescents versus young adults. And so you can gain those kinds of insights with the survey data.
Another question for you. Do the providers accessing the CSRS show their proxies? I know our providers almost never access the data themselves, and the nurses pull them from them each day.
That is a good question. My understanding is, as a non-clinician, I do not have access to the CSRS. So if you're thinking about that from the perspective of a healthcare prescriber or their delegate, either one should be able to access the system. They would be doing that at the patient level. And I apologize if I was misconstruing the question earlier. I was thinking about it from the population perspective, which you do go through the drug control unit to ask for data about your county or other geographic area for. But if you are actually a healthcare prescriber or a delegate of a healthcare prescriber, then you would do that directly through the CSRS. And I apologize, I have to double check what the system is called. It's going to be labeled on the scorecard, healthcare provider back, but it is able to be integrated into electronic medical records. So there should be an easy access to do it, and I can send additional information for people who are interested in that aspect.
And Melinda and Kristen, there's a request to have you put your emails in the chat so that folks can follow up.
We'll be happy to do that.
Okay.
And with that, I'm going to turn that back over to Jessica Dicken to talk a little bit about Partnership for Success.
Hello again. So we received a Partnerships for Success grant in 2023, and our local folks who oversee that are the addiction professionals of North Carolina. Unfortunately, they could not be here today, so I am going to talk a little bit about the work that they have done over the last couple of years. They will be entering a year 3 at the end of September, hopefully, if we get our funding from the federal government. So this grant focuses on youth ages 12 to 25. They're focusing on substance use and misuse of alcohol, cannabis, and prescription drugs. And these choices were made in collaboration with our evaluators to see what are the substances that young people are mostly using. And so we also, for the first time, get to marry the substance use concern with mental health promotional activities. And these are strategies, again, in these 7 rural northeastern parts of the state. And so we're trying to increase the perception of harm for these substances. We're trying to decrease access. We're trying to decrease the onset and progression of misuse, and then also to promote social and emotional health and resilience with this grant. A lot of the work that has been thus far has been taking these communities, some of whom have really never received any additional funding from our office through the Strategic Prevention Framework, which is a planning and sort of planning and collaboration and evaluation framework that helps communities look at the work that they're doing and the needs in their communities, and to see whether or not what they choose to do is effective and whether they want to continue to do that work. So each of the subrecipient communities receive up to $125,000. We really wanted those folks in those communities to be able to pay for a full-time or maybe a part-time person to do the work in the community, and then also to pay for supplies and materials and training and so forth. Again, you'll see over here where I'm talking about, I say the Northeast, but there's certainly communities that are definitely more Eastern in terms of Duplin, certainly Hope County and Robeson County. I don't want to forget those folks. These are communities, again, that we identified as having higher than average rates of use of these substances by young people. So the strategies that they're considering to use and have done a needs assessment to find out what it is that they need to be doing most. Folks have learned about the Lock Your Meds campaign. There's also Talk It Up, Lock It Up, which is our alcohol safe storage campaign. We also offer alcohol locks, bottle locks as well with that campaign. The 988 Suicide and Crisis Lifeline that certainly is run through folks at our division as well. Life skills, and when we say life skills, typically that's a Botman's life skills curriculum, but also there are similar programs that offer, resilience training, refusal skills, and how to, they learn more about different substances and their effect on their body as well. We've got Too Good for Drugs. Again, that's a youth program that goes K through 12, and that can be implemented in schools or after school settings. And certainly folks choose to do that as they need to. We've got the Preventure program, which is also a curriculum for youth. And then alcohol purchase surveys and merchant education. So what happens in an alcohol purchase survey is there's a group of people who are young people who are over the age of 21, and they tend to go with adult volunteers into stores to attempt to purchase alcohol. And if the store doesn't check for an ID or doesn't ask them how old they are given some education after the fact. Now, this is not law enforcement related. We do not have alcohol law enforcement involved, and there are no citations. It's simply they receive a letter saying, hey, by the way, we were here. The person didn't check for an ID. They didn't ask for an ID. So you might want to consider that in the future. And we also offer trainings as well to those folks. And merchant education is just sending all that information about the laws and making sure that they check for IDs of young people. So again, a lot of the work that has been done over the first couple of years has been getting staff together, getting them through, working through the strategic planning process of that strategic prevention framework. They've conducted needs assessments, as I mentioned, logic models, action plans, and they've done a lot of different trainings. And now they're moving into the implementation of the strategies I just talked about. I will say that anecdotally, they have definitely found that in the communities that they work, that there has been an increased community perception of harm towards underage drinking. And I think it's really important to note, because some of these communities have really never received a lot of grants from our department or even federal grants, our staff at APNC have really had to think a lot about how they adapted their technical assistance support. And as you do with anything, to adapt that to individual learning needs and styles so that the most information can get to all of the people that need it. All right, with that, I will turn it over to the state opioid response and community collaborations. Yep.
There were a couple of questions. One, is there a specific life skills program that they're doing, and what is the name of that?
It's called Botman's Life Skills.
Okay.
Yep.
And then is there any plan to replicate the compliance checks for tobacco and vapes?
Yes. So we do we pay for sites who have shown a need for tobacco compliance checks or tobacco purchase surveys. We pay for them to go and do purchase surveys in counties, and that's through our substance use prevention treatment recovery services block grant. And so there are definitely community providers who do tobacco checks. We had another Partnerships for Success grant that was funded from 2018 to 2023. And there are certain restrictions with our block grant that we can't pay for law enforcement time. And so we have to use additional state funds to pay for a SINAR survey every year. And our alcohol law enforcement does that SINAR survey in about 25 to 27 counties. They actually go out and test compliance and issue citations for tobacco. But for the PFS grant that we had in 2018 to 2023, we also were able to pay for alcohol law enforcement to go and do a check of vapor stores across the state. And I will say the results were concerning because a lot of those vape stores, and certainly for those of you who are aware of this issue, we do not have a tobacco 21 law. We do not have licensed stores. And so some of these stores are pop-ups. They come and they go, sometimes in shopping centers, sometimes in kiosks, and there's all sorts of products being sold. But we were able to do the PFS compliance checks at vapor stores. And we found a 40% they were selling to underage people, which is people under the age of 18, at a rate of 40% or more. And we certainly have shared that with local, statewide key stakeholders, local legislators. I mean, we've certainly shared that. And I think there have been some bills that have been opened up in our legislature, but I don't think have gone very far about looking at trying to legislate and oversee the vapor stores and what they're doing at local levels, especially in terms of what products they're selling and who they're selling it to. So yes, long answer to your short question. Yes, we do have that. Would we like to have more? Certainly, but we do have limited time and limited funding. So great question. Anything else, Jane, that I might have missed?
Nope, that's all.
Okay, great. I will definitely turn it over to talk. So Doug and Holly to talk about their state opioid response community collaborations and coalitions.
Good morning, everybody. I'm Doug Green. I'm the VP of Operations for Community Impact NC. I'm going to talk a little bit about the community collaboration and coalitions and their role in opioid settlement dollars and how they've helped guide some of their communities through that. And then Holly will talk about some of the SOAR dollars. Next slide. So this is a very short list of coalitions and collaborations that have had strategic input within their communities. And when I say very short, there's a ton of coalitions throughout the state, but these are a select few, such as Richmond County Drug and Danger Task Force. They were actually tasked by their county commissioners to have an input on appropriate use of funds, as well as they've been tasked with handling a funding application process within their county that community organizations can apply for each year and receive funding to help enhance or pilot new programs potentially. And they also oversee the reporting back of that. So those funded have to come back to the coalition there and present and have questions and follow-ups and things like that. The Wilson County Substance Use Prevention Coalition actually assisted with writing and implementing the opioid settlement funds within that community. They used a large part of it as an enhancement from a HRSA grant that they were holding, and that HRSA grant was running up. And so the county and community wanted to continue those efforts and enhance those efforts using opioid settlement funds Wayne County Coalition is actually receiving or was awarded funds for 3 years by their commissioners to actually help pay for a full-time position within that coalition, along with some project funding as it related to those coming out of treatment and going into community recovery style living. And then PICSA or Pitt County Coalition has been tasked and awarded funds to help provide training and encourage early identification and intervention for children and adolescents who may be struggling with substance use or mental health conditions, as well as training parents, family members, caregivers, school staff, neighbors, those that would come in contact with children or adolescents. Nash County Care, for example, they have also been tasked with helping to purchase naloxone and other harm reduction supplies for within their county. And they also help sit within a panel for the hiring of the county deputy director, or sorry, the deputy county manager who actually oversees those opioid settlement funds for the county. And now they hold a very close relationship with that deputy county manager. Pender Sup, they're actually a newer coalition within Pender County. They're growing very rapidly, very quickly. As they might not have direct involvement with the opioid settlement funds, but some of their inclusion within that is the county's actual opioid settlement coordinator has attended a large amount of their coalition training opportunities, as well as some of the larger ones within other states. She also shares data with the partners, and then they, of course, share it back with her. And she helps actually within their steering committee that oversees the coalition. And then their coalition provided a platform for collaborations within their coalition to be awarded some of the opioid settlement funds within that county, such as Pender County Schools or Coastal Horizons within the treatment side. And then also another example would be Chatham Drug Free Coalition leadership. They've played many critical roles over the past several years, being a longstanding coalition. But their leadership is a part of the Opioid Settlement Funds Advisory Committee and helps give that professional expert voice as it relates to prevention within the communities and continue those strong connections and collaborations. Next slide. So this being said, as many are may or may not be aware, a part of the opioid settlement funds, you have to choose option B to really go towards the primary prevention space as those that do that side. Some have, included in within option A around the intervention side of things, but due to this and many counties choosing option A for their chosen option for the county for opioid settlement funds, many primary prevention coalitions or providers have actually started to or have used other funds to leverage their prevention efforts while also assisting the rest of the continuum of care to help provide resources and things like that. Some of these things could be um, ARPA dollars that they received or C-19, or some other grants that have been talked about today, such as PDO, the SPF or Strategic Prevention Framework, some of those being direct federal grants or state grants, as well as some communities receiving the drug-free community grants. A lot of this funding has allowed them to hire staff to increase the need, such as things of medication lock boxes, locking pouches, cabinet locks, disposal kits, and even permanent drop boxes within their community for proper disposal of unused, unwanted, and expired medications. Um, and also purchasing campaign space or ad space within their community, and many of them using their partnerships or collaborations to help try to offset with some in kind, or if they purchase so much, the ad company will give them so much space as well, kind of thing. And so many have been able to do this through their coalitions due to the strong collaboration that they've built from many spaces throughout harm reduction, treatment, and recovery, just to have a greater overall impact together within their communities. And to talk more on the state opioid response, or SOAR, I'll turn it over to Holly.
Thanks, Doug. So as I mentioned before, I also am the project grants manager for the state opioid response grant for the prevention piece. We administer that through Community Impact NC. So SAMHSA, the SAMHSA grant was awarded to North Carolina, or has been since 2019. There are currently 7 community prevention providers that are funded to serve more than 9 counties. The current 9 counties served are Jackson, Surrey, Stokes, Forsyth, Iredell, Pender, Columbus, Brunswick, and Wilson counties. These are selected through an RFA process. Some of them are continued, and some of those have changed based on need and capacity. Next slide. So the required strategies that are designed to achieve impact, improve coalition strength, and improve community conditions at these community levels. So the strategies that are required within this grant are: 1, to reduce access to prescription drugs, and that is achieved by increasing medication storage and disposal. Let me start that over. To increase proper medication storage behaviors, and that's done through the reach and exposure of the messages, like the Lock Your Meds campaign, and provision of medication lock boxes, and also achieved through increasing safe medication disposal behavior through messages and provision of the at-home disposal kits, and increased access to permanent disposal boxes and community take-back events. Also through supporting community partners in creating policies that are related to disposal kits or permanent drop boxes. And the second strategy required is to increase naloxone access and utilization. That's done through providing naloxone trainings, providing naloxone kits to community partners, and supporting those partners in the creation of policies. The third strategy is to increase capacity to address opioid prevention. A lot of this is done through providing office-based opioid treatment providers with medication lock boxes or pouches, providing those products along with disposal kits and naloxone to non-traditional community partners, and increasing their community's knowledge of those permanent medication drop boxes, as well as installation of those drop boxes if needed in their community, and also collaborations with community partners in medication take-back events. Next slide, please. So some of the measured outcomes from the state opioid response prevention grantees this year, we actually still have 1 month, so that is not even included, but just this fiscal year so far, there have been 166 new partnerships created, 37 policies created, 178 media pieces placed, trainings, they've done 134 with over 2,000 participants. Lock boxes distributed are currently measured at over 5,800. Disposal kits over 14,000. There have been over 4,500 naloxone kits distributed, and over 8,900 printed materials, and over 8,000 other tangible printed materials, or tangible materials in general. Those range anywhere from pamphlets all the way to pharmacy bags for pharmacists to distribute as they dispense opioid medications. There'll be messaging along that folks receive along with that. Okay, next slide, please. And I'm finished. Turn that over to Matthew with Pivot Point.
Thank you so much. See if I can get my camera on. Excellent. All right. Thank you. Thank you. Good morning, everyone. My name is Matt Nannis. I'm the founder and executive director of Pivot Point WNC, based out of Asheville. We're one of the prevention programs fortunate enough to be working in collaboration with North Carolina DHHS. We bring a nationally accredited adventure-based therapeutic program to adolescents in and around Buncombe County. Our accreditation is through the Association of Experiential Education. I would say as of today, we just started with a new school year and a few new school partners. So this project has already directly served 152 students. And through our community partners, schools, and program partners, approximately 450 community members as far as prevention-based education and outreach. I will also add that due to the outpatient model and adaptability of our program, this intervention is quite replicable to a variety of locations. Next slide, please. We utilize the foundations of adventure therapy for youth ages 14 to 18 who are assessed as at risk of substance use, proper formal diagnosis, as well as those who are at risk of court involvement. Youth who are 18 years of age can be served still through our various collaborations, provided that they're not under court supervision, are referred by a collaborating school resource officer, are attending school, and that school has a school justice partnership with our programming. We work very closely with County Student Services leadership here in Buncombe, Buncombe County Juvenile Court Services, school resource officers, high school mental health counselors, and staff to ensure that the target population is reached. This is a completely non-coercive program that's anchored in client comfort and sense of overall safety. Next slide, please. So this is me getting ahead of myself. The target population is what I just covered. So I think we can actually go to the next slide, please. Yes, so this is a therapeutic experiential program. And between our leadership, our board of directors, and our staff, it's backed by over 5 decades of clinical experience and education that's relevant to the specific age group and populations that we serve. This is a peer-delivered group facilitation of cohorts of up to 10 students at a time. And we utilize hiking, paddleboarding, rock climbing, whitewater rafting, and mountain biking because we feel and have observed that these activities provide a powerful access point to both connection and vulnerability with adolescents that aren't necessarily always easily attainable in a more formalized counseling setting. Work is based on this is an example of our scaffolded structured 10-week curriculum. We meet with referring sources and our own team and facilitators to regularly update and adjust this to suit our specific client needs. Program meets once a week for 10 consecutive weeks at each of our partnering schools, and the deliverables and facilitations are completely adaptable to the specific school site, population, and the surrounding outdoor areas and facilities that we can utilize for our experiential work. Next slide, please. This is a snapshot of some of our outcome tracking. We have a number of I'm going to say iPads because I can't think tablet. That's the word. We have a number of tablets that we bring into the field with us so that we can get real-time, in-the-moment feedback and outcome tracking. We use a specified Likert scale pre- and post-assessment tracking in the field on every outing. And we also utilize a program called My Outcomes, which provides what's referred to as feedback-informed treatment. This provides not only a way to track and assess the interpersonal skill building that we're working on among the students that we support, but also the relationship, therapeutic relationship between the students themselves and our facilitators, as well as the group as a whole and our facilitators. And that's one of the key ways that we can, in real time, track the program's effectiveness. We lean in general quite heavily on best practice counseling models, including motivational interviewing with a focus on adolescent group facilitation and substance use, clinical first responder, which contextualizes the mental health reactivity and manifestations of behaviors among group facilitation. From a safety perspective, our team has either wilderness first aid or wilderness first responder. We also lean on the community resilience model, and we prioritize hiring credentialed and vetted facilitators who not only have experience in outdoor adventure facilitation, but also are coming in with lived experience, both in substance use and mental health recovery. The combination of these assessment tools and hiring practices allow us to track improvement in decision-making abilities, increased overall motivation and leadership skills, instilling purpose in the students we get to work with, improved interpersonal skill building, increased well-being and overall stress management skills, self-regulation skills, as well as general positive perceptions of effectiveness for the students themselves. These outcomes that are tracked both internally with the assessment tools I just mentioned, and also in collaboration with Buncombe County Student Service Leadership, we're able to observe have been able to observe a reduction in existing substance use and strongly expect the mitigation of future and or expanded substance use among the students we are working with, and an overall increase in pro-social interaction, which results in increased positive outcomes, peer interactions, and school performance. We can address these concerns around peer association, mental health, substance use, time management, core value identification, and general pro-social behavior in both an educational and social setting. And these students, as a result of this, are able to grow in real-time recovery capital, which is essential for healthy adolescent development. I'll also add that in year one, we are looking at an average success rate of anywhere from 72 to 78% with the aforementioned outcomes that we are tracking. You can go to the next slide. If you have time to read this quickly, this is feedback from a current prevention program parent. And I am available to read through the questions in the chat, which I was paying zero attention to. And if there aren't any, I will pass it over to Shell and Kate. Thank you so much.
Morning, everyone. I'm Shell McCall with Partners Aligned Toward Health, here to talk about our Home Remedies program. Next slide, please. We serve Mitchell and Yancey counties in North Carolina, and these are rural communities that are designated as health provider shortage areas, which also means there are limited resources in our counties for pain management and medication management. So this specific program was developed in response to a request from healthcare providers for more community-based supports for their patients who were trying to prevent or reduce opioid use. We actually had a listening session with several healthcare providers, county leadership, folks in treatment and recovery to look at what was possible in our community where we do have limited resources. So a specific aspect of the physician's request was that we have more accessible community supports around meditation, mindfulness, and self-care, and that actually came from our physicians. So a community strength for us is that we are rich with complementary healthcare providers and looked at ways to tap into that network. So as defined by the U.S. Department of Veterans Affairs, complementary health indicates that the approach can be used in place of or alongside standard medical care. Next slide, please. So we use the U.S. Department of Veteran Affairs and also National Institutes of Health as our reference points for evidence-based complementary health approaches to include in our programming. So these are things that those two entities have said, yes, this is proven to help with pain management. We're focused in this program on reducing pain, reducing reliance on opioid medications, and improving the quality of life for our residents. Sometimes we have program participants who are preparing for a surgery and they want to minimize the pain medications that they anticipate they would be taking as a result of surgery. So the Home Remedies program offers protective factors that support prevention in terms of access to care, positive community relationships, and coping skills. Next slide, and I'll pass it off to Kate.
Thanks, Shell. And to make this program as accessible as possible, since we are in a rural area with limited opportunities, we have a variety of different ways to engage with the program. The first and probably the most popular are our community clinics, which are free single-day events that bring a variety of local practitioners together, and then the community are able to come and sample different modalities. Generally, it's going to be something like acupuncture, massage, and then movement classes like yoga or Tai Chi. And this offers them an opportunity to meet the practitioners in our area, learn more about the program, and receive some of these services. We also offer, usually twice a year, a 6-week in-person educational series where different practitioners will come and talk about a specific complementary health approach, offer wellness supports, and tips and tools that can be used at home to reduce pain and stress. And it also provides an opportunity for them to develop beneficial relationships with the community that can provide positive results after the series ends. And then for the folks that aren't able to come to any of our in-person events, we also have a more flexible online course, which has videos of similar information also from local complementary health practitioners. So they're able to engage with that from the comfort of their home on their own schedule and get information on these evidence-based complementary health approaches, particularly massage, mindfulness, nutrition, things that will help them with their pain or stress that they can do at home. Next slide, please. And from the participants in the community clinics, 90% of those surveys said that they learned new strategies for managing pain and stress, and 98% of those surveyed said that they feel more empowered to make changes to improve their pain or stress. And as one of our participants said in their response, they said, "I'm more optimistic in solving my pain with these new healing modalities and really thankful for the community. It definitely gave me hope for my life and others." And this is pretty important because Wake Forest University analyzed the prescription dispensation data for the 2 counties we serve and found that the opioid prescriptions dispensed were nearly 20% of the population versus the state average, which is just under 15%. So we do have a pretty high dispensation rate in our area. And the VA did a study of their whole health program, which uses similar modalities to the home remedies program. And they found a 3 times higher reduction in opioid use compared to those who just received traditional medical care. So that's about 38% decrease in those who did use the whole health program versus only about 11% in those who didn't use the whole health program. And I didn't mention earlier, but the residents that take part in our in-person or online series are able to become eligible for vouchers, which allow them to get services with local practitioners. So they get about 5 sessions with one of the participating practitioners to address their individualized pain issues. So they're able to get several sessions of massage or take classes like Tai Chi or yoga. Next slide, please. And about a year ago, the communities we serve were deeply impacted by Hurricane Helene. Yancey County in particular suffered some of the highest damage per capita of any community in the path of Helene. So we saw an opportunity to respond, and we changed some of our plans and began to offer some short but frequent in-person community clinics at different disaster relief sites. To offer support to the survivors and those coming here to help them after the event. Because we do have an awareness that there's a correlation between natural disasters and an increase in opioid use afterwards. So we saw an opportunity to use this program to prevention of opioid use and give people evidence-based alternatives to address their pain and stress. And we did anecdotally hear from the people that we were helping that it was helpful and them continuing to address the fallout after Hurricane Helene, both the people receiving the services and those that were providing resources at these places. And I'll go ahead and hand it over to Regina at Insight Human Services.
Good morning. I am Regina Probst. I am a certified prevention specialist and program manager with Insight Human Services. Next slide, please. Next slide. So we are a private nonprofit agency, and we're based out of Winston-Salem. And we provide services for treatment and intervention for 60+ counties and primary prevention for 18 counties, which are highlighted on the map. We also do evidence-based prevention, which includes youth prevention education, community-based process, which basically means that we work with coalitions, collaboratives, and other community groups to advocate for prevention and to strategically plan and implement prevention strategies. We also provide environmental management strategies, which includes communication campaigns such as Lock Your Meds, policy work, SINAR, which is tobacco retailer merchant education. And these are our funding sources below. Next slide, please. So specifically for Surrey County, our opioid prevention work has included youth prevention education, the Too Good for Drugs curriculum, which I'll go over in just a second, the Lock Your Meds campaign, which includes medication storage and disposal efforts. So we hand out medication lock boxes and deactivation kits. We promote the permanent drop boxes and take back events. And we promote the campaign through social media, through bench ads, which are located throughout the county, and other digital media, as well as handing out the Lock Your Meds rack cards. Through a few grants, including the Prescription Drug Overdose Grant and the State Opioid Response Grant, we have done naloxone distribution and education with various partners, first responders, different agencies, businesses, and community members. We hand out individual kits along with fentanyl and xylazine test kits. The One Box, which is like an automated naloxone trainer. And then we recently partnered with East Carolina University and their HRSA grant to locate a partner to put a public health vending machine in. We also partnered with Northwest AHAC of Wake Forest University and did a prescriber training. And we served over 100 participants. And some of the topics included best practice steps for opioid prescribing, the NC Stop Act, effective ways to educate patients about opioids, and co-prescribing naloxone. Next slide, please. So I'm going to highlight the Too Good for Drugs program that we did through the State Opioid Response. This is a universal prevention program approved by the state, and we focused on kindergarten through 5th grade. It has 10 lessons, which can be done in 30 to 50 minutes, just depending on grade level, 1 to 2 times per week. And it is an interactive program, which includes role modeling, games, and different activities. And then we also did a pre and post knowledge test or survey. And just to give you a glimpse, this is the 5th grade lesson overview and areas of focus. The first 5 lessons in Unit 1 really develops their social skills. And then in Unit 2, it goes more into the substance use information and applying those skills. Next slide. So we partnered with Surrey County School District to determine what schools would best be served by the program. And we also partnered with Mount Airy Parks and Recs to implement the program in their after-school program at Reeves Community Center. And this is just a timeline of when we started in fall of 2023. And our last program ended in spring, and we served a total of 817 students. And these are just some pictures. Michelle Hopkins here is our program specialist, and she is the one doing all the great work in Surrey County. We also have pictures of our bench ads, which are located at different locations. The one in the middle is at Helping Hands Ministries in Surrey County, which is our local food pantry. The one on the top right is, I think, at a Dollar General. And then the vending machine is located at Integrated Care of Greater Hickory in Dobson at their Dobson office location. And it includes items such as Narcan, xylazine and fentanyl test strips, along with personal hygiene items, water, oral hygiene care, etc. So if you have any further questions, that's our contact information below. And I'm going to turn it over to Deanna Hale-Holland with Coastal Horizons. Thank you.
Thank you. I'm Deanna Hale-Holland with Coastal Horizons. I'm a the prevention director there, and also a certified prevention specialist. Next slide, please. Coastal Horizons is a nonprofit serving 57 counties with multi-services, including wraparound services. My focus for this is to talk about New Hanover, Pender, and Brunswick, and Columbus counties for this project. And it really is focused on the partnerships and the importance of that in this work. We can't do it by ourselves. Next slide, please. So the impact goals were with multiple funding sources, as you can see, and we've already heard that prevention providers often do have to use lots of sources of funding to get this work done. There are individual goals versus community and community goals that also overlapped. So the goals were to decrease overdoses and prevent misuse. Part of that is through secure medication storage, safe medication disposal, and also building youth skills. In the community, we want to increase access to resources, reduce stigma, and that was a big part of this campaign, and develop champions. And we also took a bystander approach to help people increase their readiness to respond. So thinking in terms of everyone being first aid trained. Next slide, please. So these are the numbers for the folks who like that. This is over 2 years, 4 counties, and still counting. Over 3,500 locking containers, that could be pouches or boxes, over 7,800 disposal kits, 14 community health boxes. I'm excited to tell you about that in just a moment. And then our youth skill building program was Unique You. We had 235 students served with that. We had 389 people trained to understand an accidental overdose emergency and to be able to respond to that. And of the folks who took the training, we always do a post survey afterwards. 87% said they felt very confident to administer nasal naloxone. And actually 100% said they felt at least somewhat or very confident. So we felt like people were more prepared. And over 1,900 naloxone or Narcan kits were distributed. And we have started a new strategy, which is called One Boxes. We have 21 of those, and I'm looking forward to showing you and telling you about that. Next slide, please. So what does that look like? It's great to hear about these strategies, but what does it really look like? We created these medication safety kits, and the medication safety kits have a locking container. They have information about the Lock Your Meds campaign. They have the location of all the permanent drop boxes in each county, and they are county specific, and we keep the list updated. And also a disposal kit in case that family may not have access to a permanent drop box, or it might not be close by. We want to make sure that they understand that safe disposal is a big part of safety in the home, and there's disposal kits and information about that. We were really looking for low-tech, low-burden methods of having a vending machine, and some of the vending machines can be quite expensive to host with the electricity. So we came up with this. It's also called a Barney box, but it's really a repurposed newspaper box. And inside the newspaper box, the community health box has naloxone or Narcan. It has disposal kits, locking pouches or boxes, and then other donations from the community, such as sunscreen, hand sanitizer, socks, and things like that people can access free at our host sites. And then our newest strategy is the One Box. The One Box is similar to an AED or a defibrillator that can be close to first aid kits. Where people gather in large places. It has automated instructions in English and Spanish, so they can walk you through just as an AED would and tell you step by step in a crisis, how do I respond to an emergency? And it also has a training mode. So each box has a naloxone kit and personal protective equipment. So we're really excited about that. And now I want to tell you, yeah, you can go on to the next slide. And now I want to tell you about some of the champions. And this is the part, this is a very short list. And it was hard to decide, but I wanted to show that there is a wide array of folks that we're working with. But one of our early adopters was Warner Temple, and he is both a faith leader and an elected official. And he was able to say, come to our church. He did a sermon about the Good Samaritan, which moved all of us and really, really helped to frame for us how we needed to approach this as a bystander and how we could get people to be ready and be prepared to reduce stigma. They host not just a one box, but they also host a community health box, and their church has really responded well and helped spread that out to other partners. And then the other partner I want to highlight is Wilmington Fire Department, who is working with the Senior Center to do Meals on Wheels, and they would look for fire risk at the seniors' homes, homebound people, and started to see, hey, there's a lot of medications out on the counter. It's a great opportunity to partner and get lock boxes to these families. And so that partnership is just a way of how it really takes a village. It takes being creative and thinking outside the box to reduce stigma, increase access to resources, and really, really reduce overdoses in our community. Next slide, please. And I will turn it over to Jessica. Thank you.
Thank you so much, everybody. We really appreciate you joining us. And here's our contact information at DMH. Dr. Angela Maxwell was also on today. And so please contact either one of us if you have additional questions. We realize we've gone over time, so I will quickly stop sharing and turn this over to Pam Morrison, who is our SOTA coordinator at DHHS. Thank you so much, everybody. It was great to talk with you and talk about our services.
That was great. Thank you so much, Jessica, and to everybody on the panel. It's so exciting to hear about the great services that are going on in our state. I'd like to introduce our panel that we have to talk about prevention and treatment. Tia Scriven is the clinical director of Haven House. We are also joined by Greta Metcalf, the clinical director, and Kenny Parmenter, the substance use program director for the Heights program, and Dr. Kelly Graves, who's the president and CEO of the Kellen Foundation. So I'd like to start out with just some brief introductions. If everybody on the panel can give a brief introduction of yourself, your organization, populations that you serve, and just a little bit about what you do. And we can start with Tia.
Yes, good morning, everybody. I am so excited and happy to be here today. So as mentioned, I'm the clinical director at Haven Health Services. We are a nonprofit serving the youth of Wake County, ages 7 to 24. We host a variety of programs that are aimed at both treatment, prevention, diversion for youth across the community and within the Youth Detention Center. Some of the programs that I cover are the multi-systemic therapy, MST, the juvenile assessment team, which is the mental health sole assessor for Wake County for youth and their family who are currently involved in the juvenile justice system and need mental health assessments. And we also provide the Seeking Safety and Brief Challenges curriculum within both the community and detention center. We also provide outpatient therapy, and we are the only problematic sexualized behavior treatment provider within Wake County. So we do a lot for our communities, a lot for our families, and a lot for youth who are experiencing different challenges. Within my role here at Haven House, I am their first clinical director. I've been here for about 2 years now. I am a fully licensed LCSW and LCAS. So I do a lot of the implementation of our programs, ensuring that we are meeting fidelity and ensuring that the youth are getting the most up-to-date current treatment.
Thanks, Tia. Greta?
Hi, everyone. I'm the clinical director at Heights. Heights stands for Helping Inspire Gifts of Hope, Trust, and Service. We serve vulnerable youth and families in the Forest 7 Western counties and the Qualla Boundary. We provide behavioral health services, mental health, substance use, prevention and treatment, restorative justice services such as mediation and community service in workforce programs up to age 24. Our substance use prevention, of course, is all ages. Our treatment is mainly for youth that are in high school, as well as the big kids transitioning into adulthoods up to 21. And we do a lot of work with our partners in building a continuum of services and really look at gaps in communities. We work closely with juvenile justice, schools, social services, and recovery communities, and faith-based communities. And I'm going to pass it over to Kenny, who could tell us a little bit more about the substance use prevention services.
Thank you all. I'm happy to be here. My name is Kenny Parmenter, and I am the Substance Use Program Director at Heights. We developed a substance use prevention education program, which is threefold to address prevention services, both in school and in the community, as well as following up with education and group work within our programs for after-school youth that are referred for juvenile justice and or prevention of juvenile justice services. And then we screen all of the kids that are involved in our program to determine if they need another level of care. And we would provide that outpatient therapy through individual or group services based on the level of need. And then with the Jackson County Department of Health and Human Services grant, we're really focused on opiate prevention right now and partnering with community members and getting out into the community to educate on Narcan and distributing Narcan and helping families understand the risks that they pose with their kids and different substances that could be of use.
Thanks, Kenny. And Dr. Graves?
Good morning, everyone. My name is Kelly Graves. I'm the president and CEO of the Kellen Foundation. We are based in Greensboro, North Carolina, but serve the state. We are a behavioral health agency that also includes an integrated dual diagnosis clinic, as well as several other specialty clinics. We serve about 12,000 people a year, 99% of which are served for free through grants and philanthropic partnerships. We do a good bit of treatment, but we also do a ton of prevention, outreach, education, and our particular focus is on trauma and trauma recovery. And so integrating that into everything we do. We're one of only a few sites in North Carolina that's a National Child Traumatic Stress Network site. So we focus on that heavily. I did want to mention we recently launched an integrated hub. So we now have what's called the Kellen Foundation Hope Hub. It's a large 35,000 square foot facility that's intended to be a prevention and treatment hub for families. And so we have our services there, but multiple other services are co-located with us now because we know a lot of the families that we're talking about and serving have lots of different needs. So the prevention of other types of issues is integrated into the Hope Hub beyond just the behavioral health piece. So food pantries, tutoring, GED classes, SAT prep classes, sports clinics, nutrition workshops. It's a very large facility, and we're excited to continue to integrate those services to head off other things that could develop for families.
Yeah, because we know that everything is related and everything leads to something else, whether that's a risk factor, a protective factor, or both.
Exactly.
It's just great to hear from everybody. So what trends have you guys seen in the last 6 months to a year as far as adolescent substance use goes in terms of the types of substances being used, onset intensity of substance use that's going on in your communities and with the people that you serve? And let's start with, how about Greta and Kenny?
Yeah, I'll take that one. So working with the adolescents that we serve, we haven't seen as many overdoses in Jackson County, but looking at the data, our county is at high risk. It's much higher rates than the state average. And so if that's true for adults, that would also hold true for adolescents, because we have found that there's exposure in the home to the substances that the parents are using. It puts kids at risk. We've heard a lot about the Lock It Up initiatives, and we've been trying to get on board with that. Getting access to parents has been rather difficult. Another thing to be of note, when I looked at the data for my presentation over the summer, adolescent substance use for females specifically is on the rise. And then the biggest growing trend right now is non-smokable tobacco, such as Zyn packets. Vape use is actually on the decline due to reports, but a lot of that data is not being tracked well in schools. So I would suspect it hasn't totally dropped as much as the data shows, but there is a trend of shifting to non-smokable tobacco.
And Dr. Graves?
I would echo
What
all
are
of
you guys
that.
seeing?
The one thing that I am seeing in trends is that for when, you know, we're still seeing a lot of the vaping, but we're seeing a lot more creative ways, and you know how vapes have been reformatted to look like different things, highlighters, et cetera. We've seen a higher use of secret vaping, and just creative ways to hide that. So that's one of the things that we're doing a lot of parent education about, and school education about the different ways that vapes can show up and what they look like. So that's one of the things that we've seen kind of a much more creative way to engage in those substances. And so that's triggering for us the ability to educate in a different way as well.
And Tia, what are you guys seeing?
Yeah, everything here that's already been stated, I just want to echo again, especially as we operate Wren House, the only at-risk youth runaway and homeless shelter within a 2-hour radius of the Triangle. We are seeing that more secretive use of vaping. We're also seeing an increase of non-discriminating uses of substance use. So typically when we see a youth who comes to Wren House or comes to our treatment, they have one specific substance that they have been using or utilized or have a history with, and now we're seeing that trend is kind of branching out to it doesn't necessarily matter which one they start with. They like to mix and match now.
So
one other point that I noticed, we did a survey of our youth, and they identified gaming and social media as the highest addictive behavior that they're at risk of right now.
Yeah, definitely. So when you're working with youth, how is working with teens different than working with adults? What are some different strategies that you employ when working with the adolescent teenage population? And we can start with who hasn't started first yet. How about Dr. Graves?
Sure. So a couple things, of course, like teenagers, their brains are still developing. Their emotional maturity is not as high. Their impulse control is not as strong. Their decision-making ability. So one of the things that we do that's a little bit different with teenagers instead of adults is really think about ways in which to what we call put in a speed bump before an action. A lot of times with adults, we kind of make a bigger plan. And so a lot of the times with the teens, while we engage in bigger plans of like what to do instead, sometimes because of their maturity and impulse control, thinking that far ahead and that down the line, that's not on their radar. So what we try to do is do more time specific interventions and educations where we're just trying to put in a speed bump before you make a decision on whether to engage in different substances, rather than completely looking longer term in terms of their actions. So that's one way in which we kind of shift our focus when we're working with teens.
Tia, what kind of strategies do you guys employ differently with teens than you would with adults?
We do a lot of the communication and education surrounding harm reduction and education surrounding safe choices and risk and decisions.
And Greta and Kenny?
Yeah, I would say one of our biggest secret ingredients to this is engaging youth in creative ways. So similar to Pivot, we use a lot of our outdoor activities to help make things fun and inviting, and being able to have the opportunity for kids to connect with each other and form that belongingness. But we do a lot of the rafting, the hiking, the biking, all those fun things to engage.
That sounds like fun. I want to go out and visit. So for my next question, and in the interest of time, there are oftentimes misperceptions of what substance use treatment does and does not look like, and what prevention does and does not look like, often as a result of decades of misinformation and stigmatizing rhetoric. So how has your messaging changed? Tia, you can start with you.
Okay, so I think for us, it's definitely become more of a destigmatization conversation. So once again, surrounding that harm reduction and really empowering the youth to learn more about safe coping measures and the risk and decisions that they make for themselves. We definitely take a very collaborative approach to working with youth and families. So we don't try to start by saying abstinence is the only way or that this is completely wrong and pointing fingers or anything like that. So we try to build that rapport, build that trust, and we know that there may be some underlying variables such as comorbidity or underlying diagnosis. So we try to address that in conjunction with those conversations.
Kenny, Greta?
I've noticed that I would reiterate what he was saying, that we're focused on this harm reduction aspect and trying to incorporate person first language. When you have this adult population, there's a lot of terminology around like, I am the addict and I have to accept the fact I'm an addict. We try to put the person first in terms of, I'm an individual who struggles with substance use, and not letting that define them. And that's been a recent shift that we're really trying to help kids understand in order to overcome a lot of those struggles. We've also seen some of the taboo around the moral model of addiction is hard to overcome, with schools, especially, and parents thinking that this is a choice and that they can either choose to use or not use. But we've seen kids as young as 5 years old being given vapes by their parents. And so I would argue that there's no choice in that matter, and that like addiction can easily come, and it doesn't discriminate against various populations.
Yeah, 5-year-olds can't decide what to eat for dinner. So, Dr. Graves, what about you guys? What kinds of changes have you done in your messaging?
Yeah, I think the primary thing for us is the integration, separate from additional services that families might need. I think there's a positive shift to understanding that, the traditional models of you go over here for substance use support and you go over here for mental health support. I'm seeing a stronger trend, and we certainly integrate those things together. And I think that has been shifting more and more. I think there's still lots of room for growth in that space to be able to address those. But that is one of the things that we focus on, that it's almost impossible to tease those things apart, and really treating and supporting and preventing all of those things together. We also have been trying to shift narratives. So when we think about the prevention piece, we talk a lot about how we're not just going out and educating about substance use and mental illness, like mental health issues in a these need to be addressed ways, but how do we shift the narrative to really building mental wealth? How do we build our coping skills, build our regulation skills, so that when we're faced with the decision about whether to use this or not, or somebody says, hey, try this, we have built up a mindset that it makes a good decision easier.
Yeah, so building resilience, changing the narrative, changing the conversations, getting away from finger pointing, blaming, and the just say no days of the early 80s. And I mean, I say early 80s, but that went on for so long. I really appreciate all of this great information. In the interest of time, we do need to cut a little bit short to move to our next presentation. So thank you to all of our panelists. Everybody give some clap emojis. Thank you so much. You guys are doing amazing work in your communities, and it's so exciting to hear about all of the work that you're doing and how you're engaging people in a broader way. So next, I'd like to introduce to the group Dr. Shuchin Shukla. He is an addiction medicine consultant with the North Carolina Technical Assistance Center. He is also the medical director of Greenville Comprehensive Treatment Center and the chief medical officer of Goldie Health. Dr. Shukla is going to present an overview on treatment of substance use disorders for adolescents and the neurobiology of addiction in the adolescent brain. So turn it over to Dr. Shukla.
Great. Thank you, Pam, for that introduction. Can everyone see my slide? Should be a brain looking back at us.
Yeah, we can see him.
Great.
I was giving a
Nice.
thumbs up, but I had turned off my
Great. So I know time is short, so I'm going to dive right into this. I just want to say I make these slides both as a addiction medicine specialist and family medicine physician who's treated adults and children and babies, but also as a father who sees the world in terms of the traumas and resilience factors out there for my kids, and as well as a former kid, like we all were, who has memories of my own traumas, but also the things that built resilience in me, and also had my fair share of substance exposure, both in my community and my peers, and etc. So that's good. Why is this topic important? I know we started this conversation with some epidemiology, but just as a reminder, opioid misuse and use disorder amongst adolescents has been declining alongside a lot of other substance use over the last years, but overdose continues to rise. With the most recent set of data, it's the third most common cause of adolescent mortality in the US. You can see here on the right side, past use, illicit substance use amongst 12th graders in the bottom right has declined over the last 20 years, but overdose in those teenagers has increased, particularly through the pandemic and the rise of fentanyl. Overdose is still a top cause of mortality for adults, particularly adults age range 20 to 40s. And so we think of teenager substance use and opioid use, both in terms of the risk for them as teenagers, but also I think for the risk of them as future adults. Because 90% of adult substance use, whether opioids, alcohol, tobacco, 90% of that substance use disorder in adults starts with exposure and initiation as an adolescent. So let's start with looking at how this all develops. Why do teens use substances in the first place? And how does that eventually lead to opioid use disorder? So this is data from an MMWR. It's a major publication of the CDC, looking at teenagers being assessed for substance use disorder treatments. They're entering a treatment facility of some kind or a treatment program of some kind. And what they report are their reasons for using substances. And so this may be too much data here, but you can see broken down by type of substance, but on the very left, you can see overall for all substances. Teens use substances for the things we think they use it for, and they didn't have an option for getting high or being bad, though that is often a term or a phrasing that some might use. But as you can see, it's to feel calm, mellow, relaxed is a top reason, having fun or experimenting, help with depression, anxiety, helping with concentration. That's a particular use among stimulants, as you can see. Boredom, staying awake, helping fall asleep. These are all things that I experienced as a teen, and I found ways, both healthy and unhealthy, to address those needs. And so if and when we get to my last slide, if there's time, I hope we all remember that when we think of prevention, the deepest, most primary of prevention is how can we replace the needs of teens, these very normal human needs, with things that are healthy rather than things that are unhealthy. So if and when teens use unhealthy substances, and I will note that alcohol, marijuana, and nicotine, which is not on here, are the three most common substances used by teens because they are the most accessible and in some cases very legal or at least decriminalized. And you can see that the reason for those uses is a little bit different for alcohol and marijuana, for instance. So once a teen or any person starts using substances, why do they keep using substances? And so there's a great little graph I use probably in a lot of presentations if you've seen my presentations before. But most humans, most living things exist on this spectrum up and down here of at the top feeling mellow or euphoric or feeling good, and on the bottom feeling anxious, dysphoric, feeling bad, and in the middle is normal. And all of us, right, we wake up on the right or wrong side of the bed. We have a good day or a bad day or good moments and bad moments. We're fluctuating up and down on the scale, but mostly staying near the center. And this is a normal way living things negotiate their realities. It's the way we learn how to do things, as basic as walking and talking and eating and drinking. And what substances do is they work in the system, and we'll hopefully talk a little bit about the neuroscience behind this. I'm going to keep an eye on the clock here. So in this example, here's a teen, and there's a narrative that goes to the paper. You can see the citation at the bottom, who is prescribed an opioid medication for an injury. I think it was a sports injury. You can see they take the medication as prescribed. They take it as their bone or body is healing, and the side effect, if you will, of the opioid is this feeling of euphoria that brings this person up on the scale. And then as that medication wears off, it brings them back down. And that cycles up and down and up and down. And what you see over time is a reflection of, or a behavioral reflection of tolerance, where the medications peak, decreases over time, and the set point, or almost a thermostat, decreases as well. Because humans and biology, and even amongst other creatures, like homeostasis, likes being near the center. And so this medication is pushing this person's neurotransmitter system off kilter. And so it's making changes, which we'll talk about, to get back in the center. Here in the middle at about day 10, you can see this person, maybe they're following the STOP Act and they had a limitation on their opioid prescriptions and they stopped taking it. And they go through a period of withdrawal. And some people, teenagers, adults, have withdrawal after a short course of medication with opioids or other dependence-causing substances. Some people, it takes a while to kick in, but nevertheless, in this case, this person goes through a period of withdrawal, and they get over it, which withdrawal will eventually end, and then they get back to normal between days 20 and 200. But what changes in the interim is this substance use, particularly in teenagers, changes the way the brain interacts with stressors and different stimuli, good and bad, and in this case, bad with the stressor. And so here, the stressor causes a period of dysphoria like it would in anyone else, but it might be that exposure to substance as well as exposure to other traumas increase the depth of that dysphoria and increase the trigger for a person to think substance use will make this better, will relieve the dysphoria I'm experiencing. And in this case, this person relapses in this hypothetical situation with heroin, with an illicit opioid, and you can see the sort of use gets more erratic and closer together, and the tolerance develops deeper. And this is a extremely simplified, extremely, with the amount of time we have, description of, at the individual level, how someone's initial use can develop into dependence. Dependence can then lead into a use disorder. A use disorder is not just this first category, the physiologic, the development of tolerance and the experience of withdrawal. To diagnose a use disorder, whether opioid or alcohol use or nicotine use disorder, you really need at least a few elements, or one element in addition to physiologic, from the risk and harm or lack of control category. And so I'm not going to read this out loud. You can see the slides and Google SUD criteria from the DSM. But really, this is what typifies use from use disorder. Though the majority of adults with a use disorder started use as an adolescent, the truth is the majority of use, being very careful with my words here, the majority of use does not result in use disorder. Most people don't develop a problem. And of course, different substances have different rates of this, but most people don't develop a long-term disorder, or if they do, they recover without really gaining the attention of the system, of researchers, of the healthcare system. But those that do develop risk and harm and continued use despite this risk of harm and this lack of control criteria, they're the ones we would call a use disorder. So how does this reflect amongst in the brain, in neuroscience? So at the most microscopic level, the molecular biology of the brain is a bunch of nerves, and the average nerve can have hundreds, if not tens of thousands of connections, and they all connect in different ways. This just shows as an example of the connection which happens at what's called the synapse between two nerves. This is how everything happens in the whole body in terms of digesting your food, speaking out loud, breathing, standing here, thinking thoughts, having memories, smelling smells. This is all nerves. And so the synapse is this connection between nerves where the electrical impulse of a nerve is translated into a chemical signal between nerves. And so these connections, these thousands and thousands of connections amongst the millions upon millions of nerves in our body, happen in extremely diverse ways. It could be, all these different connections from one end to the other, one end influencing the connection of another nerve, one end connecting the signal processing of another nerve, and on and on. And I show this not to really go too deep here, but just to show the complexity of the human brain is, I would argue, one of the most complex things that exist. AI has nothing on the brain, and AI is created by brains, so I doubt it will exceed brains, personally. But when it comes to substance use, whether legal or illegal, whether food or drink, whatever it is, external things affect the system. And so this little slide from NIDA shows here on the right the way dopamine, for instance, works here, but in the synapse between two nerves. Dopamine released from one side goes to the receptor on the other side. Enough receptor activation creates stimulation and sends the message on to the next nerve. And in this case, cocaine, though this again is a crazy simplification, cocaine works both by stimulating the same receptors without having dopamine at the same concentration, but also prevents reuptake, so that the previous nerve is clearing out that signal. So it's not just a holding your hand on the horn and not taking it off, like never-ending signal. And so substances affect nerves at the microscopic level, and then these nerves, particular types of nerves, in this case dopamine, are concentrated in different parts of the body and different parts of the brain. And so dopamine, I'm sure many have heard of dopamine before, and the idea that it corresponds with what's called the reward center, the pleasure center. Is the part of the brain not just for pleasure, but really about learning, learning how to do anything from the moment you're born or preborn through the end of your life. Your dopamine is working to reinforce things that help you in a lot of cases, and the amygdala, another part of the brain, reinforces learning to avoid things that hurt you or scare you. And so these changes at the microscopic level affect broader parts of the brain and those connections between each other. And so very complicated slide, but just to point out different aspects of a use disorder, from the experiencing of intoxication to the experience of withdrawal and negative affect, and then through to craving and preoccupation, anticipation. Those all correspond with different parts of the brain. And we can see with things like MRIs here on the left, that the brain changes at the macroscopic level, at the neuroanatomic level over time, just the same way it would change if you learn to pitch a baseball with your left hand when you're a right-handed person. Your brain would change, your MRI would change with that learned behavior. In a lot of ways, using substances over time changes the brain as a learned behavior, and specific parts of the brain light up in different ways. A lot of times folks will compare this to a heart, healthy versus disease. And I think that is a wrong comparison, because the brain is not disease in this case. It's just learning to navigate its world using substances, which have in some ways benefits to individuals that use them, but as we mostly all agree on, a great amount of risk, and increasing risk with how substances in the marketplace change and access to them change. So are we doing on time? Okay, so what is actually different about the adolescent brain? As I think some of the other amazing speakers pointed out, the adolescent brain is different. It is still growing, just like their bodies are growing. Depending on the researchers, some will say the brain is still changing and growing all the way to age 25 and beyond. But you can see here, this little schematic shows that different parts of the brain are maturing at different time periods, depending on the region. And so, just this reminds me, when I was thinking about my slides and making these, a lot of research shows kids 5 and under are much better at learning languages than they ever will be for the rest of their life. And that's because here you can see some of the speech and motor areas which are involved with speech and learning and processing. Those are developing and maturing at a really young age. And so, kids that learn a lot of, hear a lot of Spanish are going to learn Spanish, and try to learn that as an adult with your Duolingo, it's a lot harder. Still thinking of substance use as a learned behavior, you can see that certain parts of the brain in the teenager are developing more actively, which particularly is the limbic system, the part of the brain involved with emotion-driven behavior, reward versus fear, the dopamine parts of the brain, novelty seeking, thrill seeking, seeking new experiences. If you remember your teen years, you might remember those feelings. The parts that are less developed, but also developing, also very affected by the things that are exposed to it, or it's exposed to, is the prefrontal cortex, which is involved with more complex thought and abstract thinking, cognitive structuring, and really a lot of things like impulse control and planning for future consequences, delaying your immediate gratification for delayed gratification. And so this all makes sense to how we kind of intuitively think and feel about substances and teenagers also. And I like to think of all this as the brain, adolescent brain particularly, is like a plant. It's growing, and those nerves are both, some parts are growing and some parts are being pruned and decreasing in their connections. And so giving the right fertilizer and not the wrong fertilizers is really important to reduce risk and then make that tree grow big and strong. So when I think of what are the main ingredients that increase that risk of substance use to substance use disorder, I think of one being two elements. One being substance exposure, right? You got to have substance exposure to develop a use disorder. And like I said, the adolescent exposure is very much correlated with future risk. Research shows the earlier a teen or a kid is exposed to substances, the more likely they'll have ongoing use and a future disorder. Gateway drugs are real. I learned a lot of misinformation or in my DARE program when I was a kid, but one thing was real, which is gateway drugs are gateway drugs. And nicotine is one of the prime gateway substances, which, as a previous speaker mentioned, now it's becoming these Zyn products and more of the deregulated products. So nicotine exposure really predicts future risk of other substance initiation and use, and then future use disorder. And some researchers even think of opioid use disorder as the final stage in this long continuum of substance experimentation, use, and then disorder. The more severe that use and the longer goes on, as well as the earlier it goes on in someone's life, the more likely it predicts future substance use. So that's very much what I would call a dose response curve with how substance exposure predicts use in teens. The second element that I would point to is really increasing risk is trauma. And trauma, man, one slide, maybe I have two on this. Trauma is a big old T and a very small T, but all that fills a huge warehouse. So as much as I can say about it is we have our ACEs that I'm sure this audience is very familiar with on the right side. So of your big old, it's hard to argue that these are traumatic events. But I throw in that a lot of the micro traumas, the experience of racism, the experience of gender violence, both, physical as well as verbal and emotional gender violence, a lot of things related to identity, a lot of things related to socioeconomic status. That all contributes, and not to mention things like lead poisoning, even subacute lead poisoning, traumatic brain injuries, including subacute traumatic brain injuries. I'm talking about just headers and head injuries for youth football players, and things like neurodivergent experiences like autism and ADHD. All of these have been known to increase the risk of substance use and substance use disorder. What this does here on the left is what I call a feedback cycle of trauma, because the more trauma a person or a teen experiences, the more likely they'll have substance use, as well as these other experiences, witnessing violence, experiencing violence, carrying a gun and maybe perpetrating violence, suicidality, mental illness, unstable housing, poverty, unintended pregnancy, STI, condomless sex. All these feed into each other. Trauma increases the risk and likelihood of these experiences, and then these experiences increase the likelihood of further substance use and further trauma, and it creates a vicious cycle. And heck, you could even say, and researchers point to this, that this creates an intergenerational cycle of trauma and substance use. This is all more commonly experienced in LGBTQ teens, Black and American Indian, Alaska Native teens, female teens, and then homeless and teens that are involved in foster care, justice involved teens. Like substance exposure, these traumas are like a dose response curve. The more you have, and over longer periods of time and at younger age, the more that affects the brain, just like a chemical exposure. And this translates all the way back to that kind of molecular level through what we call epigenetics. So that's actually not changing your genetic code, but the expression of that code, the on-off switch on your individual genes, down to the level of how much your body produces cortisol in response to stimuli, the way your amygdala works, which is the fear system, the way your dopamine receptors work, which is your reward system, the way your emergency system works, and the sympathetic nervous system, etc. This is all connected, molecular, macro level, your experience of your reality, intergenerational. It's a lot. So what can we do about this? I'm not going to talk too much about the elements that our previous speakers talked about, particularly the kind of direct primary prevention for teens at risk, but we'll touch on a little bit of that. I'm going to go a little both deeper and more widespread. So the first step for those at risk is the idea of SBIRT, screening, brief intervention, and referral for therapy. American Academy of Pediatrics and various other experts groups recommend universal SBIRT for all adolescents, and that might take place in a variety of settings, in school, in clinics, etc. This is a little chart from NIDA, I think NIDA, or maybe SAMHSA, looking at some screening tools that can be self-administered as well as administered by a professional that work. They're evidence-based for teenagers, and so I know, you know, a lot of places I've worked have used CRAFT, etc. Once adolescents identified as potentially having a use disorder, they should receive a brief intervention for mild disorder or just problematic use. And that might entail motivational interviewing, kind of understanding their stages of change. If you're not familiar with that, I have a little summary, little colorful graph there. You're going to identify risks and strengths and help them build on those strengths and minimize those risks. You're going to provide harm reduction interventions. I'm really glad my colleagues from Wake County mentioned harm reduction. You make a plan and follow up. You want to have a long-term relationship with this teen, ideally. For kids with more risk and a higher need for care, referral for treatment is appropriate. And, you know, depending on the professional you are or what your role is in the system, knowing your community providers, who they are, is really essential, and knowing what you can provide yourself is essential. So I'm going to focus a little bit with my remaining minutes here on medication treatment for addiction. So there are FDA-approved medications for opioid use disorder. There are 3 medications that are approved for 18 and up, and one of those is approved for 16 and up. However, there is some data and research showing off-label use of these medications is both safe and effective, and is allowed, but insurance coverage can be tricky, as well as finding providers. At least in adults, you know, doing any kind of research, especially research on substance use, is very challenging in teenagers in terms of consent and identifying, identifying folks in this vulnerable population. But what we do know from our adults is use of these medications in these populations is associated with improvements in the rates of use, in their overdose risk, and other negative health outcomes, and often even social outcomes like interactions with the criminal justice system and, you know, employment and things like that. And so because of that, use of these medications for teens diagnosed with opioid use disorder is recommended by a variety of national expert bodies of treatment providers. Minors in North Carolina can consent to treatments, and it can be kept confidential, including with medication, even without a parent's permission or knowledge, as long as they have been assessed as having appropriate decision-making capacity. So, you know, even a 25-year-old can potentially not have decision-making capacity and to make those decisions, but teens can in this state. Except for methadone. Methadone does need parental permission to do. The way, in long story short, the way these medications work is that they interrupt that cycle. If you remember that graph of going up and down and that continued use, because of the experience of withdrawal, which is pretty much extremely excruciating and terrible, and becomes a learned behavior of that since it's so terrible. These medications work by interrupting that withdrawal symptomatology, by stimulating those receptors that are feeling the loss of that stimulation from the illicit or legal opioids. They stimulate those receptors enough so that people, the teens, don't experience those symptoms, and then later don't experience cravings. And so these medications can be both available from an OTP, otherwise known as methadone program, but OTP, which there's, I'm going to get this wrong, I think 50 or 60 different programs in the States. I might have the numbers wrong, so somebody might have to put that in the chat box, but they are available in many counties in the state. We are rich in OTPs, and counties that don't have them often are still a long drive, but a county away from another OTP. OTP is the only possible site for methadone treatments. Meds are administered and dispensed, they're not prescribed, so there's no external pharmacy. When you go to an OTP, you're generally taking an observed daily dose. And then eventually, as you stabilize and get to the right dose of your medication, you get take homes. And so you don't get a prescription to go to another pharmacy. Because methadone is long acting and does have some risk, you titrate that medication slowly. Buprenorphine is available at OTPs, however, it has less risk, which I don't remember if I kept that slide. And regular counseling is required in those settings. Buprenorphine by itself, however, is available through what is sometimes called OBOT, office-based opioid treatment. Any provider in America with a DEA number can prescribe buprenorphine. That could be primary care providers, pediatricians, OBGYN, psychiatrists. Heck, your dermatologist can prescribe buprenorphine if they want. And so it's a lot more accessible because the medication is less risky. Both meds work extremely well, as my next slide shows. So this is the highest level of research, a systematic review and meta-analysis, but this is all adult research. But it just shows the profound, and I mean profound, unparalleled to other, pretty much most 99% of medical interventions that exist in our species, in our human reality. Nothing works as good, or very little works as good as bup and methadone for reducing mortality and risk amongst people with opioid use disorder, particularly those involved in on the right here, people involved in the criminal justice system, which teens at risk are often engaging in some of those systems, juvenile justice. So in the interest of time, I don't know if someone's trying to tell me to hurry up in the chat box, I can't really see it, but I will say there are great ways to reduce the risk of overdose. Access to medication and treatment is a very big part of it, but so is things like educating families and teens, as I know colleagues here in the presentation have talked about, supporting resilience building activities in high-risk groups, which I'll just skip to that. And so when I think of prevention, I really like to hone in on the idea of resilience, because there is certainly telling teens about counterfeit pills and teaching them refusal skills, having lockboxes. Those are all have varying levels of research. But I'd like to point these four also well-researched and well-evidenced interventions that are a lot broader and I would say losing funding now for particularly the last year here, but over the last many decades. And that's things like social clubs, support groups, anti-bullying kind of interventions in schools, making schools more accessible with social emotion learning opportunities. And, for me as a teenager, that was soccer, sports, clubs, art and recess. When I was a kid, there's a lot more of that than my kids experience. Having behavioral care, healthcare in schools, so important. And then really supporting parents. I think something the pediatric world loses sight on is we can't support the adults and look at adults as the enemy of kids' development. I think we're doing a great disservice to in a lot of different aspects. And so providing things like affordable housing, living wages, school lunches, this has all been shown to reduce trauma, build resilience in families and kids, and actually a lot of these interventions reduce the risk of substance use in the future. What doesn't work is, amongst many things, I'd point out here is forced treatment in general does not work. At best, it's as good as voluntary treatment, but forcing treatment, at least in adults, because I don't think there's much research on kids, but forcing treatment really is something that is going to hurt communities, in my expert opinion, and should not be implemented. And on the left, this is maybe also controversial, but research does show drug seizures, particularly at the community level, actually increases hyperlocal overdose rates because it disrupts the local drug market and makes drugs more dangerous. Even though it looks like you're getting drugs off the street, more dangerous drugs usually replace that. And so I'm not going to talk about ongoing challenges. I'll close up there. My email is at the top, and then that's the QR code for the website for the North Carolina Technical Assistance Center. We are funded by DHHS to provide free TA and support to programs that serve their communities to reduce overdose risk. And you can see our areas of expertise are pretty broad, so please reach out and check out our website. Thank you so much.
Thank you. That was great. I did see, I know that we are already over time. There was one question in the chat, Dr. Shukla, that just
Sure.
ask how young the meds have been used effectively off-label.
I can't say off the top of my head. I personally know 15-year-olds that have been treated, and I have not seen below that. I will say there are not enough buprenorphine prescribers. There was great research showing something like close to 90, if not a little over 90% of teen overdose survivors that went to an ER, and I forgot what part of the country, if it was a national survey, but 90% of those teens, they experienced an opioid overdose, and 90% of them did not get opioid use disorder medication within the next 6 months. So that just shows there's a crazy need for opioid use disorder treatments. But I will say that a lot of overdose in this state and beyond happens to teens that probably have not had an opportunity to be identified as having a use disorder. And so I do think that we really need to be teaching harm reduction and risk counseling as well as resilience building in our teens. But back to the actual question, I know at least down to age 15, I've seen treatment.
Okay, great. Thank you so much. Well,
Sure.
we are out of time. Just want to say thank you again to everybody that presented, all the panelists. Want to say thank you to the team that helped put this OPDAAC meeting together, and then to the Governor's Institute again for providing the platform. This was a great meeting. There was so much information shared. I know that a lot of it moved very quickly. But just want to give a reminder that the slides and a recording of the meeting will be posted on the DHHS OPDAAC website, and an email will be sent out once that is posted. It typically takes a week or two. So just kind of be on the lookout for that. And then also want to announce that the next OPDAAC meeting will be held on December 4th in Raleigh at the McKimmon Center, and there will be a virtual option. We'll have more information and registration links and all that good stuff coming out in the coming months as well. But other than that, I think we're good. I just want to say thanks one more time to everybody who joined us today. And if you have questions or need anything, please feel free to reach out.